The whole idea of drug development, it's a little dry. So the biggest challenge we have is making this very exciting, and interesting, and something that's really at hand. And I think starting with the education a couple of years before the first therapeutic entered the market, which we hope will be next year, has been one way to do that. Starting with, it's kind of interesting, through nobody's plan, we started with agents that were used for supportive care. So everybody's a whole lot more comfortable with that than when you're treating somebody with curative intent in the early stage cancer setting. So starting with filgrastim and now pegfilgrastim, I think will give people experience and make them feel more comfortable with using these agents. And then as these agents get out into the practice, it's really making sure that people understand, how we're using them, what the sort of extrapolation means, what the clinical evidence means. Comparing the different biosimilars is going to be extremely difficult because they all have very good data that supports their use as biosimilars, so that's helpful. I think, understanding the lack of immunogenicity is particularly helpful. But then I think that another challenge that providers face, so whether it's whatever kind of clinician is treating the patient, is what the pharmacovigilance means. Because one of the things that's required by the regulatory agencies is that there is very careful pharmacovigilance, so that you look at safety and relatively efficacy in different indications. And so, you have to report based on this little 4-letter abbreviation after the antibody any safety issues that come up. So who's responsible for pharmacovigilance, how it's reported, how it's easily done is something we still need to understand, because there isn't a drug yet that is a therapeutic agent. The pharmacovigilance is still being worked out.
We have in the US currently 11 approved biosimilars and more than 20 in the pipeline, which will come during the next months or years. And of course, this is good news for the patients. For the physicians, of course, it is kind of a challenge, because if you have for the same reference product several biosimilars, you need to know the data, whether there are any differences. And in the end, I think what is the good news for everybody is that due to the fact that several manufacturers are producing biosimilars for the same reference products, there's a price competition. And as it is with other goods you produce, if you have more than one company offering this compound, the likelihood that the price will be lowered is rather high. And I think this is a good news. As I said, the fact that you have several biosimilars for the same reference product might cause more discussion which one to use. At our hospital, we discuss which biosimilars to choose, and usually they are not submitted and approved at the same time and go to the market. And then from time to time we discuss whether we should change anything. But the likelihood to have, for example, the reference product and 2 or 3 biosimilars on stock for the same reference product, this likelihood is not only in our institution, but I think at many institutions not something being considered. It needs to be rediscussed together with the pharmacist and this commission for the use of drugs within the hospitals, and then it needs to be decided. And of course, the price issue is something where the pharmacists and the regional and national agencies, in a sense, will be part of.
I don't think it really changes our management, but it changes the management worldwide, because in many countries, for example, you're only allowed access to 9 weeks of trastuzumab, or you have to pay for every bit of trastuzumab you receive, so out of your pocket. And so having a less expensive drug will completely change access around the world. So since we know these are agents that can cure patients, it's a really big impact on disease management. It's also our hope that by having, and this sort of this may be pie in the sky, but by having a lower cost option for drugs that can be given for a long time, that it will free up money for drug development and for paying for other drugs that are also life-saving. For example, the new area of immunotherapy, which adds a huge additional layer of cost and complexity in patient care, particularly our patients with the most aggressive diseases that stand most to benefit. And it's interesting, I mean, we continue trastuzumab forever, right? I mean, people in other countries are always like, what? So, you know, because they stop because it's so expensive, they can't continue. But, you know, if I have a patient who has metastatic HER2-positive breast cancer and they go on trastuzumab, maybe now with pertuzumab, and they go their chemo, they have a great response, they stop the chemo, and they're sitting on those two antibodies, they can stay on those two antibodies forever. And at some point, I'll say, usually at 10 years, okay, now you've been on therapy for 10 years, let's stop the therapy. Of course, the patients are very anxious about that, but still they've stayed on for 10 years. Many other countries, probably most, don't do that because they can't afford the drugs. I think Western world much more so than the rest of the world. But with, you know, significant cost savings, not 15%, it would have to be a lot more than that, people will be able to stay on the drug for longer and potentially will have better survival as well. So I think that there is a potential impact just on patient outcome by having the drugs be more accessible. It's just not so much in the US.
The availability in the future of biosimilar biologicals will change the way of treatment in countries who are not in the situation to be able to afford these drugs so far. And I think there it will be a major change for the treatment, and the usage of, for example, filgrastim or monoclonal antibodies will lead to better outcomes in the treatment of these cancer patients, and therefore is to the benefit of patients being treated there. In the Western countries, I consider the situation now that the availability of the reference product as well as now the biosimilars did not change very much of the usage of these compounds overall. I think here the situation with regard to quality of treatment is not really affected.